Good afternoon, everybody, and welcome to today's SVS VQI Updates and Registry Revision webinar. My name is Carolyn Morgan. I am the SVS PSO Director of Clinical Operations. Before we get started, I wanted to go over a few brief housekeeping items. We will be keeping all lines muted throughout today's presentation, but encourage you to type your questions into the Zoom Q&A box. This allows us the opportunity to answer your questions as time allows at the end of the presentation. In the event that we are unable to answer your questions during the session, we will reach out via email following the webinar. And with that, let's get started. So for today's agenda, I just wanted to introduce and let everybody know that there are some new intermittent claudication guidelines that came out at VQI at VAM or during VAM. We're going to review some of the registry revisions, and then I'm going to provide some additional updates. So there are, like I said, the Society for Vascular Surgery Clinical Practice Guidelines for the Management of Intermittent Claudication. So I provided the link at the bottom of this slide for anybody that is interested in visiting the claudication guidelines, and it will also be offered on the VQI.org website. Intermittently, I like to review just some of the more difficult or confusing questions that have come up. These slides actually came from Dr. Ben Brook from the University of Utah. He presented this presentation a number of years ago at VQI at VAM, but I just wanted to quickly review the difference between the conventional and eversion approach for carotid endarterectomy. For the conventional approach, it can be done with or without patch angioplasty. And this is where there is a longitudinal incision or arteriotomy within the carotid artery itself. And it typically goes from the common carotid into the internal carotid. By opening up that incision, you can identify the plaque, remove the plaque, and then typically at the end, as you can see in the third image from the left, a patch is placed over the incision, and then the entire incision is closed. When we talk about eversion carotid endarterectomy, it is typically where the carotid artery is completely transected. It is completely removed. You can see that in the very first image on the left and in the middle image. What they do in the pane on the right-hand side, you can see this middle image. They pull back the arterial wall itself, expose the plaque, remove the plaque, and then they completely sew the transected artery back on to its original, usually, like I said, the common carotid. So that's the difference between the two. Typically, most centers do the conventional. I have to be honest, I would need to go to the carotid committee or to a surgeon champion to ask them what the benefits and risks or why people would perform an eversion over a conventional. But I just wanted to share that information with you. We're going to spend the majority of this webinar addressing or reviewing some of the smoking cessation variable revisions. The first revision that I'm going to talk about is in the demographic tab. Now, I do recognize there are a few legacy registries out there that still have a general tab, but typically it is in the demographic tab. We ask within the current data the patient's smoking status, whether it is never, prior, or current. And as you remember, Current is defined as within 30 days of the procedure. Now, here's the change. If you say the patient is currently smoking, a new variable will populate. It is called pre-op smoking cessation counseling history. Typically, before, there were variables that said no, discussion with physician or provider, offered smoking cessation counseling such as 1-800-QUIT, or you were given some medication options. These have been revised. Now, the very first variable that will show up, it will say pre-op smoking cessation counseling history. When you click on that, you will have three options. The first one is no, there was no counseling. The second option is the patient declined counseling. And the third option is yes, counseling was provided. Now, for purposes of reporting, when we start collecting the reporting for the post-op variables, and even if we do any reporting on the pre-op variables, if you select patient declined, or if you say yes, you will get credit for both. Now, let's say there is a scenario where there's documentation that the patient declined smoking cessation counseling, but counseling was still offered. Remember, you can select either one of those. I would encourage you to select yes, counseling was provided, and then in the comment box, put patient declined. The new definition for pre-op smoking counseling history is the time frame was decreased from 6 months prior to the surgery or procedure date down to 2 months. Additionally, the counseling historically was you were allowed to document counseling given by any healthcare provider, and now it has changed to not only 2 months prior to the surgery or procedure date, but it must be provided by an interventional team member. Now, what is an interventional team member? It can be a vascular surgeon, it could be an interventional radiologist, it could be a neurologist, an interventional neurologist, it could be a cardiologist, or any member of those physicians' teams, meaning it could be, as long as they work for that physician's practice, it could be a physician assistant, an APP, NP, etc. We've gotten a lot of questions just since this change. What defines smoking cessation counseling? It can be any combination of these. It could be, and as you can see, these are checkbox selections, so you can select all of them if you want, but it can be a discussion with the provider. It could be a professional referral, or it could be a NRT or medication prescription. So again, the interventional team is defined as a physician or medical doctor, a physician assistant, a nurse practitioner, a resident, a fellow, APP. It refers to a healthcare professional who has an advanced education and clinical training beyond a registered nurse. So within the post-op or post-procedure tab, some people refer to PVI since it is a percutaneous stick as a procedure. Some people say it's post-op. I'm trying to use all the terms to be all inclusive. But again, we broke out was post-op smoking cessation counseling and or treatment offered. The select options are no, patient declined, and yes. If you see both patient declined and yes, you will get credit for answering patient declined and yes. But I always like to give the physician or the practice credit for actually doing the counseling. You will notice that in the help text, there are references to offered and provided. These are synonymous, but with the next registry revision, we are going to harmonize the verbiage to be counseling and or treatment provided after surgery or procedure and before discharge. That is a key component for your post-op smoking cessation counseling for those patients that had a smoking status of current prior to the procedure and or surgery. In order to get credit for the counseling and or treatment offered, the counseling or treatment offered must be offered after the procedure or surgery and before the patient was discharged. New to the registries is the smoking cessation variables were added to the 30-day follow-up form. They are exactly the same. We ask about for if patients were discharged as a current smoker, then within your 30-day and your long-term follow-up form, you will automatically see, has there been any smoking since discharge, excuse me. If you say yes, we ask if smoking cessation and or treatment was offered. And then within the 30-day and long-term follow-up, the typing of smoking cessation offered can be provided by any physician or healthcare provider. It does not have to be part of the interventional team or part of the team that performed the procedure. So for purposes of 30-day follow-up, the time frame includes from discharged to the most recent 30-day follow-up, whether or not there was any smoking or smoking cessation counseling and or treatment provided. And then for long-term follow-up, it is the same thing. Has there been any smoking since the last, if you filled out a 30-day follow-up, it would be from the 30-day follow-up to the long-term follow-up. And Betsy, is that right? I'm going to have to get back to you. I am taking back what I am saying. It is, even if a patient is documented as smoking within from discharge to 30-day, you say yes. For long-term follow-up, it is any smoking from discharged to the current long-term follow-up form. So patient smoking status at long-term follow-up since discharge is any smoking from discharge to long-term follow-up.
Correct.
Had to think about that one for a minute. You get so turned around.
I couldn't come off mute, sorry.
That's all right. So I just want to remind people of another little nuance that we collect for our smoking cessation variables. If a patient had a smoking status of current at the time of discharge, and you say that smoking cessation counseling and or treatment was offered, in your post-op procedure tab, you say yes. And then if you say NRT medications, they were offered to the patient, At long-term follow-up for that patient, you will be asked their current smoking status. If their current smoking status is no, we just ask, are they still using the NRT medications? No, they're not using them. Yes, they are using them, or you don't know. I think the intent of the variable is just to see how the patient is doing approximately 1 year out, and if they were able to completely stop, or are they still using some type of support mechanism. Another revision to the registry, we are adding some cholesterol lowering
Wait, just
alternatives.
one quick question. We have 3 questions on smoking cessation that you just went over. Do you want to do those now or at the end before
Sure.
we? Okay, they're all pretty easy. Is the smoking cessation counseling given post-operatively able to come from the discharge paperwork / education?
Yes, it is. You know, I equate it, ideally, we really do want someone to talk to the patient. But I equate it to a physician giving a patient a prescription for a statin. You hand them a piece of paper, you say, here's your prescription. You hand them their smoking cessation material. We don't know typically if the patients fill their prescriptions. We hope that they read their instructions, but just having a packet of smoking materials within their discharge instruction, it does count.
So then we have another question on that same point. If a patient was given smoking cessation resources like 1-800-QUIT-NOW on their discharge paperwork, does this still count? So
Yes.
yeah. And then we have, I think there's some confusion about interventional team. I think most people are thinking that the interventional team is just the surgeon and thinking of a specific registry. So the question is, you need to be specific about interventional team members and who they might be. In your example, you included a cardiologist. It seems like you're going outside the interventional team.
Okay, I apologize. I should have said interventional cardiologist that's performing the procedure. So you have your vascular surgeon, you have an interventional radiologist, not just a radiologist that reads x-rays. You have an interventional cardiologist, you have an interventional endovascular neurologist. It is the physician that is performing the procedure and any member of his team or her team, excuse me, their team.
Yeah. So I think that's it. And I also think some, like an open AAA would only be, so I think a lot of that depends on the registries you belong to, if that verbiage actually hits home or not. And then the last question.
I'm sorry, excuse me, Melissa.
Mhm.
Just think of it, it is anybody, any team member of the individual that is performing the surgery or the procedure. Does that make it more clear?
I think so. I just think it's a good part of the discussion. I think it is. And then the last question is, will we be correcting the verbiage to say and or? It's
Yes.
confusing the way it is.
Yes. I apologize. This is the way I was asked to label it, but and it is defined that smoking cessation includes physician, healthcare provider, counseling, professional referral, NRT medications, or unknown. But we will be correcting that. Yes.
And that's it for now.
Okay. So now moving on to your cholesterol lowering alternatives. There are some new medications out on the market that are actually supported by some insurance companies that are statin alternatives, I'll call them. One of the classifications of medications is called PCSK9 inhibitors. This is an acronym for proprotein convertase subsilin Kexin type 9 serine protease. Your PCSK9 inhibitors fill a unique therapeutic niche in selective high-risk patients, such as patients that have a family history or are statin intolerant. They may have a lot of leg or muscle cramping. They might not be able to achieve the appropriate LDL-C levels with conventional therapies. And so I did break one of my own rules. You will see in the pre-op medications, they are all in alphabetical order, except after the statin, there is a variable that starts with the letter P. I did that intentionally because I didn't think it would make sense to put these in the middle of an alphabetical list. It made more sense to keep it compartmentalized around the statins. There are 4 select options. One is none, one is Repatha, one is Leqvio, and then the 4th option is other. I was asked already why we do not have a selection for patient non-compliant. It is because the physician champions didn't think that it needed to be added, and I was told that these were the 4 selections they wanted for this variable. I do want to call out that the PCSK9 inhibitors do not include niacin or standalone azithromycin. The other cholesterol lowering alternative are your ACL inhibitors. These are like your bempedoic acid target lipid and glucose metabolism. They work on inflammation, and the primary effect is the reduction of cholesterol synthesis in the liver, and its administration is usually not associated with all the terrible muscle side effects that a lot of our statins have. Again, your ACL inhibitors do not, and I will tell you, the NOT has already been corrected. The typo NOT has already been corrected on the electronic data collection forms to include niacin or standalone azithromycin. So it includes your next Lexatol and your next Litzit. For purposes of discharge medications, this is really important, and I wanted to make sure that we really emphasize this. I just want to make sure that Katie has provided everybody and make sure that everybody is aware. For this reporting measure, cases are excluded if discharge statin is no for medical reason or in-hospital death occurred. And we talk about aspirin and P2Y12s, but for the purposes of this webinar, I just want to focus on these 2. No for medical reason. If the statin isn't doing anything for the patient, it's not reducing their LDLs, and they are placed on a statin alternative, the patient, you can clarify with your physician or ordering physician group that if when you see that the patient wasn't discharged on a statin, but was discharged on a statin alternative, if they agree that you may code no for medical reason. At this time, statins and your PCSK9s or your ACL inhibitors are not prescribed at the same time. So as long as you have documented no for medical reason, you will not be included in the discharge medication reporting measure. The other reasons are patient allergy, patient intolerance, not medically indicated, or hospice. Some help text revisions. There were revisions to the TVAR branch treatment select options so that now that there is a select option for each, or there is a help text for each select option. The statement, long-term follow-up communication with the patient through a center's patient portal or through email is not accepted as a long-term follow-up visit, was added to all of the long-term follow-up contact by variables. Preoperative aspirin. Patient has taken aspirin. This is the new part. Anything in red is new. Preoperatively within 36 hours of the surgery. And preoperative is defined as before the start of anesthesia or incision time, whichever comes first. It also includes drugs containing aspirin, such as Agrinox. Your daily dose of aspirin. So the daily dose we define historically in black, as you see. Select the closest dose if exact dose is not listed. 100 milligrams is not offered in the United States. We added that in there from our Canadian friends. This is the dose that the patient takes on a daily basis. It is not to be included as a preloading or supplemental doses that a patient may receive prior to the procedure or surgery. It is what the patient takes on a regularly scheduled basis. For your PVI, ABI variable, the link to the clinical practice guideline was added to the help text. For the PTAB, post-procedure thrombosis variable, we had some questions from the industry around the industry project that is centered on this variable, and they asked or requested that the help text be revised to include, for PTAB cases, target lesion thrombosis refers to the thrombosis of the PTAB device, not the artery being bypassed. So it'd be thrombosis of the graft that was used to bypass the blockage, not the inflow or outflow native vessel itself. And then for the CEA, CAS, hyper and hypotension help text, the link was added, Dr. Molasses' publication link was added to that help text for easier access for all of our centers. The next registry revision webinar I anticipate to occur fall, September, October-ish of 2025. We're going to be talking about a TVAR registry minor revision. There will be new help text revisions coming. There's going to be education on the abstraction of comorbidities for the preoperative variables and documentation requirements. And there will also be education on medication abstraction and documentation requirements. And with that, we can open it up to questions.
So we just have one registry revision question about how to maybe place all the lipid lowering agents in one place. So for that one person, I would please submit this through FIVOS so that we get quarterly suggestions and we review them all together. And I don't want this to get lost in the mix. And that's all we have right now.
Okay, I guess we could do a parent-child type relationship. That would be an enhancement request. And yes, having those enhancement requests sent through to FIVOS helps in the maintenance of the ongoing lists that we keep. I will share with you that we've had some requests or enhancement requests to relabel the variable or living status of homeless to unhoused. The recommendation that has come from the AQC is it will align with the Housing and Urban Development, or HUD terminology, and their terminology is homeless. So we are going to stay aligned, much like we are aligned with the Census Bureau and defining or listing out of our race and ethnicity variables.
So this is there's another question that is an abstraction question. If you could submit that through 5 support about the daily dose of aspirin, we would greatly appreciate that. We just like to keep track of how many times questions are asked on a certain topic in case we need to do a help text update. So if you could please submit your aspirin question.
You know, I was thinking back to my days when I worked in the lab, and you'd be standing there and you'd be coming to the end of a PVI or a carotid stent. You know, the patient came in taking their daily dose of Plavix, but occasionally they would give like what I call a boost or booster dose of Plavix. It's the same thing with Plavix or clopidogrel or any of the other variables for your pre-op. It is the dose that the patient takes on a daily basis, not your loading doses, not your boosting doses that they receive in the hospital or during the procedure.
And then there's a question about if you're new and your predecessor is retired, is there a way to get center contact information for other centers? I would strongly suggest reaching out to your regional league data manager. They are a wealth of information who can provide additional support, and obviously there is always 5 support.
And if you don't know who your regional lead data manager is, reach out to me, C. Morgan, at svspso.org, and I will help connect the two of you together.
Absolutely.
Well, thank you everybody very much. I hope you all have a restful, fun rest of your summer. Stay cool, stay dry, stay safe. And if I don't talk to you before, I'll talk to you in the fall. Thank you very much.
Thank you.
Bye-bye.